Okay, well, welcome everyone to teaching today. Today, I thought we would talk about chronic diseases in children and adolescents. We often talk about acute diseases, acute infections, pneumonia, diarrhea, malaria, fever, those sorts of things, but we don't often talk about chronic diseases. And yet chronic diseases, when you add them all up, they're very common. And they make up a lot of the cases that we see in the wards. And I just wanted to not so much talk about individual chronic diseases today, but talk about chronic diseases overall and how they affect children and adolescents and how they're different from acute diseases and how we need to have different systems for managing children who've got chronic diseases. So that's what we'll talk about today. When you look at you've seen these pie graphs before. This is a pie graph of all the causes of mortality in children under the age of 5. And mostly we focus on acute respiratory infections and other infectious diseases, diarrhea and malaria and HIV and measles. But this is overall, this is globally in children under the age of 5, the Global Burden of Disease Study. But if you look closely, there's another segment of the pie that's quite large, and it's about 10% of all deaths, and it's made up of non-communicable diseases. So other conditions like cancer and epilepsy and cerebral palsy and asthma and chronic lung disease and diabetes, those types of conditions, nephrotic syndrome, etc., they all make up a fair proportion, at least percent of all child deaths globally. And that's the case also from data we have about PNG, certainly is the case. This is, for example, the data from last year from the Paediatric Hospital Reporting Program. And I've just listed all the admissions from asthma and rheumatic heart disease and congenital heart disease and cerebral palsy and epilepsy and diabetes and cancer. And you can see that they make up a lot of admissions. So 1,616 admissions, 1,616 admissions, and 159 deaths. So the case fatality rate was 9.8%. So about 10% of all children with chronic diseases died in hospitals. But these chronic diseases alone made up 8% of all the admissions that we had, 31,000 admissions, and 16% of all deaths. So that's the figure to remember, that about 16% of all deaths will be from these chronic diseases. Now, individually, they might be relatively uncommon, but together they're quite common. And I want to talk really about how common these conditions are today and what they all share in what they have in common, if you like, and how we need to understand them as a group of chronic diseases where children need a different type of care to those that we normally provide for acute diseases. This is some data from the United Kingdom, and of course it doesn't necessarily apply to PNG, but I think it's striking to me that the rise in chronic diseases. So these are, even if you just take the children 0 to 4 years and 5 to 15 years, you can see a progressive rise in chronic diseases in children. This is even up to in the last 20 years. And what you can see is that by the age of 15 years, then close to 20% of all children have some chronic disease. And of course, they could be a chronic physical disease or a chronic mental health condition or some other chronic disease that they have been identified with. There are differences. I want to first of all talk a bit about the differences between acute and chronic diseases. Well, I think mostly that will be familiar to you, but just to make a distinction, the onset of acute disease is usually abrupt. It usually happens quite abruptly, whereas for chronic diseases, the onset is often gradual and often insidious. They occur often without knowing until the disease is quite established. The duration, of course, of acute disease is very limited. You get treatment for an acute disease, you get better. But for chronic diseases, by definition, chronic diseases are lengthy, and sometimes it's an indefinite duration of of illness a child has. The cause for acute diseases are usually just a single cause. Sometimes for chronic diseases, there may be multiple causes. Not always. Sometimes there's a single cause, and sometimes the cause is uncertain, very uncertain. For cancer, most causes of cancer, most childhood diabetes, for example, the cause is uncertain. Sometimes it's genetic, and sometimes it's multifactorial. The diagnosis and the prognosis for acute diseases, we're usually quite accurate in understanding the prognosis for acute diseases. Usually they get better unless it's very severe. But for chronic diseases, often the diagnosis and the prognosis is less certain. We may have less certainty about what's actually going to happen to the child. For medical interventions, drugs and medications, they're usually quite effective for acute diseases, but for chronic diseases, they're sometimes very effective and sometimes they're a bit indecisive, uncertain whether they'll have a strong effect. And sometimes adverse effects of those medications will be as significant as the treatment itself. For acute diseases, the outcome is almost always a cure is possible, but for chronic diseases, there's often no true cure, and the child lives with that condition right through childhood, adolescence, and sometimes into adulthood. For most acute diseases, we don't have a great deal of uncertainty about what's going to happen. The child will get better usually, so there's minimal uncertainty, but uncertainty for chronic diseases is quite common, and that has an effect on families and the way they think about it. And then perhaps the most important thing for acute diseases, usually it's us, the health professionals, we know most about those acute diseases. Parents are less knowledgeable. But for chronic diseases, I think patients and their families have complementary knowledge and experience that is very important for the management of those conditions. So, as I said, increasingly a high proportion over the last 20 years, increasingly a higher proportion of children in the children's wards and in the clinics have a chronic condition, either a communicable condition, an infectious disease that's chronic, or a non-communicable disease. So we've got the old chronic infections, tuberculosis, HIV, rheumatic heart disease, but we've also got an increase in non-communicable diseases, congenital heart disease, as children get some treatment and they survive, or they may get surgery and they survive. Asthma and other chronic lung diseases, they're on the rise. Cerebral palsy is probably on the rise because of more survivors who have very low birth weight or have birth asphyxia. Epilepsy is also on the rise. Kidney disease has become quite common, nephrotic syndrome in recent years. Diabetes is being more identified. Many children with cancer are surviving treatment and therefore ending up with chronic illness. And there's more ex-premature babies that are surviving. So there's a lot of changes in the epidemiology of chronic diseases that have happened in this last 20 or 25 years. And it's good to understand those things. Many chronic diseases are diseases of poverty. Not all, but many are, or at least the outcomes are. So children who are not living in poverty often have a very good outcome from chronic diseases because they get treatment, their families are educated, they understand how to look after them, whereas children who live in poverty often have a very poor outcome from chronic diseases, and we just need to be aware of that. Now, I think in hospitals, we're very good at acute diseases. We can manage acute infections very well, but often for chronic diseases, we take what I consider a recurrent acute approach to such children. So children who have, for example, some neurodevelopmental problem, every time they have a seizure, they come into hospital and they get treated as if they've got acute meningitis, when actually they probably just have epilepsy and they need their epilepsy managed and not have antibiotics for a meningitis and not have lumbar punctures and lots of interventions. So instead of having an acute approach, a more chronic approach, we have still acute approach to these patients. And we often then neglect the longer term issues for these patients. We treat their acute infection, but often neglect the longer term issues, which go beyond the hospital. They go from hospital to discharge to being in the community and lots of things. I wanted to, as I said, when you think about each individual chronic disease, they're relatively uncommon, but when you put them all together, there's a lot of common features, common issues of children who have chronic diseases. The first one is that the population that's involved, they're less likely to be under the age of 5 and more likely to be school-age children and teenagers. And so if we are starting to be more interested in school health and in adolescent health, then we need to get good at managing chronic diseases. All these children need feasible goals of treatment. They're a bit different for acute infections, aren't they? We treat an acute infection, we expect the goal of treatment is cure and the child gets discharged and then they're fine. But for children with chronic diseases, they need feasible and often personal goals of treatment and individualized or personalized treatment plans which I'll show you some shortly. There's often a question about how to achieve optimum development potentials and quality of life. These are really important aspects of managing children who've got chronic diseases, is to try to improve their quality of life and their development potential. That means many children with chronic diseases may not have a normal development potential, but they have an optimum development potential. They often can develop a lot more than what they are. And some children with chronic diseases have a perfectly normal development potential. They can go to school, they can go to university, they can get jobs, they can engage in the community and have families. And we sometimes neglect the development potential and the quality of life that such children have. There's many issues as children get with chronic diseases get older about adherence to medications. Now, of course, we mostly think of adherence to medications around TB and HIV, but that applies to children also with other chronic diseases where they have to take medications every day, and it's often lifelong, such as like HIV medications, but it might be taking the child's insulin or any other medication for thalassemia, or such as iron chelating therapy for thalassemia, preventer agents for a child's asthma. There may be issues with adherence, and sometimes there's issues with not so much adherence, but the availability of such medications. So we need, as paediatricians, to think about how to optimize the chances of a child taking their medications and how to provide them with a good supply of their medications. There's often a common issue in children with chronic diseases about where to care for such children, and it's not all about being in the hospital. And much of the care of such patients occurs closer to home, in the community, with healthcare workers that are closer to their community, or in an outpatient setting. Many children with chronic diseases get taken out of school because it's thought that they are too sick, or they can't cope with school, or their parents are worried about them. But actually, it's much, much better if they stay in school. Certainly for children with epilepsy, very few of those children go to school. We know that from studies that have been done. Also the same for children with thalassemia. Very few of those children go to school, and it's much better if they are able to attend school. And sometimes that requires that we try to teach teachers about the management of such conditions. I said that for children with chronic diseases, the understanding, the knowledge doesn't just rest with the doctors and the nurses, but it rests also with the parents, and they can contribute a lot to the care of their children, as can the children themselves. And I think there's good evidence now that if you start teaching the child themselves about the condition, then they can be the experts in their own condition. Sometimes for children with chronic diseases, such as cancer or HIV, there are issues of prognosis and sometimes ethical issues, and sometimes end of life issues or palliative care issues. But for most chronic diseases, they can be managed and a child can have a good quality of life. Sometimes if children have chronic diseases and they're living in, I would say, dysfunctional families, then they may not get the care that they need. And this becomes therefore an important child safety or child protection issue. And then lastly, one of the common features of all these chronic diseases is that eventually these children hopefully will grow into adolescents, and then they'll need transition to adult services. And I don't think we're very good at this transition to adult services. In fact, almost no country is good at that transition from paediatric services to adult services. And when that happens and when that should happen and how it happens is we're not very good at. The issue with chronic diseases often for families is that they can be quite costly if we have the wrong model of care. If we keep children in hospital for a long period of time, it can drive families into poverty. And that's not so much that it costs a lot of money. The fees for hospitals are high, but it means that families can't work. That there are often high healthcare costs. And if we don't try to prevent complications in children with chronic diseases, then they get more complications and the costs are even higher. But if we can have systems that look after children properly with chronic diseases, then they can go on to make very strong contributions to society and return far more than the treatment costs. So it's very cost effective to look after children with chronic diseases, and all children, regardless of what their condition, they have a right to good health care. And so it shouldn't just be for children with acute conditions, but children with chronic conditions as well. I wanted to just give 3 examples of some evidence on how to manage chronic diseases. And again, what you'll see are commonalities between these conditions. So I'm going to say something about asthma, something about epilepsy, and something about diabetes. And it won't be so much about the medical management, although there'll be a little bit about that. But mostly it'll be about the common features of these diseases and how we can take a chronic care model to look after such children. The first thing about asthma is that it's very important to have a written personal management plan. And this is a management plan for a child who has chronic asthma, and these plans are on the Paediatric Society website. But they're simple plans that children can have that say something about themselves and something about their type of disease, something about their asthma and how severe it is, in terms that people and the child themselves will understand. So this child has described his asthma. Joshua James has described his asthma as he gets sick, short-winded, he gets breathing problems, wheeze and cough, and he can't talk. And he's on a long-term preventative agent 2 times a day, where he takes 2 puffs plus his Ventolin puffer if he's very sick. And he likes playing rugby, so he takes Ventolin before playing rugby. And if he gets very sick, then he has to take Ventolin, 6 puffs, and then if he gets very sick, then go to hospital and have prednisolone and more Ventolin and sometimes oxygen. And here is an emergency plan that he can enact both at home and can be enacted by healthcare workers if he presents to hospital, and that's Ventolin, 6 puffs every 1 to 2 hours if he's very sick, and prednisolone 20 milligrams each day, or 2 times a day if he's very sick, and oxygen if his oxygen level is less than 92%. He sometimes gets some other medications, Atrovent, aminophylline, magnesium if he's very sick, and this personalized management plan just says other things about him. He likes drawing and he barracks for the Maroons, and he says, talk to me about my asthma. I know a lot about it. And many children with asthma, by the time they reach this age, this boy is 7 or 8, he will have a very good understanding of his asthma, and he can learn about it. And I think that a lot has advanced in the management of asthma in the last few years, particularly the understanding that preventative therapy in children with moderate or severe asthma can be very effective. And the World Health Organization has recently endorsed the use of inhaled corticosteroids plus long-acting beta agonists, and including a medication called Symbicort or Seretide, and they're long-acting beta-2 agonists. So a little bit different to salbutamol, they last a bit longer. And so children don't have to take them very regularly. They may take them just a couple of puffs twice a day. Remember, this is only if they have moderate or severe asthma. The two preventers that have been endorsed or recommended by the World Health Organization now are fluticasone, which is a steroid, plus salmeterol, which is a long-acting beta-2 agonist, and budesonide, which is also a steroid, plus formoterol, which is a long-acting beta-2 agonist. And they come as a medication called Seretide or Symbicort. They're very effective in children over the age of 5, so not under 5, but over 5, with moderate or severe frequent asthma. So you've got to have pretty bad asthma to be eligible for these medications, but they can make a very big difference to the frequency and severity of asthma attacks. They were endorsed just last year by the World Health Organization, and if children are taking them, they've been shown to reduce hospitalization, reduce the use of salbutamol and other short-acting beta-2 agonists, which probably have too many side effects like tachycardia and other jitteriness and other things. There's some good data on the use of personalized management plans, and I won't go through this in much detail, but just like the personalized management plan I showed before, this is a study from India where there were 60 children with moderate persistent asthma, moderate severity persistent asthma in India, and they gave home management plans similar to what I showed you before, and they found that those children had fewer exacerbations of their asthma, fewer school absences, and an improved symptom score. So their asthma was better because they had a written personalized management plan. The other thing about asthma that has been proven is that if you teach a child properly about their asthma, then their control of their asthma will be much better. I won't go through this study in too much detail, but this is a study from Jordan in the Middle East that showed that among school children, if you have older school children in year 11 who were trained to teach younger children about their asthma, so only for children who had asthma, then that was highly effective. It meant that the younger kids in year 8 and 10 had a much better knowledge of self-management of asthma. They were able to resist smoking, which is obviously a bit important thing for children to do, not to take up smoking, and they had improved asthma quality of life scores if they engaged in this education program within schools. Similarly, there's many other studies of group or school-based education of asthma, often children teaching other children about their asthma. So it's clear that if you educate the parents, that's not enough. You have to educate the child. And that applies to children with any form of chronic illness, that they need to be educated about their own condition, because then they'll become experts in it and not be so scared of it. They'll have knowledge is power to manage your own condition. There's some other studies of this preventer therapy that have been very successful. A study in Brazil that showed that when there was more availability of puffers with preventers, inhaled steroids plus long-acting beta-2 agonists, then more children had better control of their asthma. And similarly in Africa, in Zambia, previously there was a lot of salbutamol syrup or elixir being used for asthma, and that's not very effective as a preventer agent. In fact, it's not effective as a preventer at all, and it's not very effective to control acute asthma. But when they introduced the steroids and long-acting beta-2 agonists as a preventer, then it was highly effective and more children had much better control of their asthma. I wanted to go now to talk a bit about epilepsy, and epilepsy is in some ways even harder condition because many children have more complex neurological problems. Some children have just epilepsy, and some children have epilepsy, of course, with other complex neurological problems, sensory problems, or neurodevelopmental problems, or cerebral palsy. But that has led to a lack of interest in epilepsy in general, I think, around the world. And but there are some good studies now from many in Africa and some parts of Asia that show that you can improve the management of children with epilepsy if you have a focus on those children and trying to reduce what they call the treatment gap, which is there is a concept called the treatment gap, where it's anywhere with epilepsy in Africa, it's anywhere between 25 and 100%, which means that in some settings, no children with epilepsy receive proper treatment, and in some children the gap is 25%, which means that even of 100 children with epilepsy, only 75 children will actually receive the right medications, and this applies, I think, to children with epilepsy and PNG as well. But it can be overcome. Often the supply and cost of drugs is very substantial, and that can lead to non-availability of effective medications. And certainly, while phenobarbital is often available, and some of the other medications that are more expensive are often not available, but they should be. These basic anti-epileptic medications should be available in all hospital pharmacies, and it shouldn't be that children have to go to or families have to go to a private pharmacy and pay very high private pharmacy rates or costs for these medications. There's been some good studies from this group in Africa, the African Epilepsy League or Foundation, to show that if you do if you do try to improve education about epilepsy within communities, and if you do try to incorporate epilepsy into standard health services, and you can reduce the treatment gap, then children have a much better outcome. And I think the best study of this actually is from PNG, and it's from Dr. Kaspari Amond, the paediatrician now in Goroka, and she followed a large group of children who had epilepsy for almost 2 years. And those children, if they had good follow-up and consistent medications, at the start, many of these children, the 47 children she followed, had very poor control, either poor or very poor control. But after 20 months of follow-up and adjusting their medications, then 92% had very good control. And that was mostly based on, because of availability of medications, mostly based on the use of phenobarbital and having a consistent supply of that medication. And for some children, for 23%, they needed phenobarbital plus carbamazepine. So you can, with the available medications, as long as you have a consistent supply and you follow these children up, they can achieve much better control of their epilepsy. And lastly, I wanted to just touch on type 1 diabetes, because that too is increasing around the world. And I'm sure you know that the features are weight loss and thirst and polyuria and often vomiting when the child gets very unwell with ketosis, and then confusion and coma. And many children present with the last symptoms, confusion coma and vomiting. But when that's the acute state aspects of management and the acute presentation. But we need to be able to manage these children long term too. And here's a personalized management plan for a child who had type 1 diabetes. And you can see, again, her name is there, her date of birth, so you can work out her age, her parents' names, her contact details, the type of illness she had, so diabetes type 1, insulin dependent. She needs 2 daily insulin injections. And what happens if she has an exacerbation of her diabetes? Well, she says it's not common unless I miss my insulin or miss meals or have fever or vomiting. If she gets an exacerbation, what happens when I get sick? Well, she becomes tired and has vomiting. These personalized management plans are useful for the child for their education. They're useful for parents for their education, and they're very useful for healthcare workers, because then if a child brings a plan, then the parent will, the healthcare worker will know exactly what they need to do. Remember, many healthcare workers are not very well trained in the uncommon chronic diseases like diabetes, and often the parents and the child will be more familiar with what the child needs. This child, the Joy's long-term treatment was with insulin, and there's the doses of insulin she receives: 18 units in the morning and 9 units at dinner time. She needs to eat regularly. What else stops me getting sick? Well, eating regularly 3 times a day, checking my blood sugar every day. Extra medications she needs to take on sick days. Well, she may need to take more insulin or keep having regular meals even if she feels sick, and check her blood sugar levels more often. And sometimes she needs to have barley sugar or some sort of sweet sugar if her blood sugar is low. And the emergency plan is to check her blood sugar. If it's low, give barley sugar or sweets or a meal. If it's high, give more insulin and check for fever or infection. And these are the contact details of the paediatrician or the nurse who was looking after her. And as I said, just knowing something else about the child. She says she likes school, and she also says, ask me about my diabetes because I know a lot. And I think that this sort of information, just one page of information that has information on it that a child will understand, that parents will understand, and it'll be informative for health workers, is really fundamental to managing children who've got chronic diseases. So I just encourage you to make up personalized management plans for children who have chronic diseases. Teach parents and children to give insulin as well. They'll become the experts in type 1 diabetes, or in asthma, or in epilepsy. I think there's a lot can be learnt from some of the research on tuberculosis. This is not a non-communicable disease. Obviously, it's a communicable disease, but a lot can be learnt from programs that have been successful in the management of tuberculosis. And one thing that can be learnt is that extensive and careful follow-up is very needed. And studies have been done in even remote rural areas. This is from Ethiopia, about the management of multi-drug resistant TB. And you wouldn't think that there'd be high treatment completion rates in a remote rural area in Ethiopia for MDR TB, but they were able to have quite good treatment completion rates by having a roving outreach nurse who supervised treatment and gave treatment. Well, in those days, injectable drugs. Of course, we use now oral medications for MDR TB. But the point was having a healthcare worker that would go to communities or go to homes and provide support to the patient supporter to assist with the DOTS program. And in addition to this, in this program, they also provided some social and economic support to families. So they gave food baskets or psychological support, social support in some ways. And for people who are destitute, they gave support with housing. And so I think what it tells us is that social support is very needed for many patients with chronic diseases. These were mostly adults with chronic, obviously multi-drug resistant TB, but there are some parallels for many children that we see who've got chronic diseases that live in poor circumstances. So in summary, all children with chronic diseases need a personalised management plan. They need access to medications, often hard to get medications, but as paediatricians or as nurses, we need to be advocates for getting these children the medications they need. And often they'll be a bit outside the standard treatment, but they're medications that they need. And we need to come up with guidelines for the management of these chronic diseases. And these children need one trusted doctor or nurse. It doesn't have to be a paediatrician, but usually they'll all need to see a paediatrician at some stage. But they might, if they live in a more remote area, they might have a paediatric nurse, or they might have a general doctor who can also help the family. But these families need at least one trusted person who can help look after them and has what I would say corporate knowledge of their condition. And we should be teaching the child, not just the parents and the caregivers. We should understand the importance of peer-to-peer education. So if you've got more other children in the clinic who've got a chronic disease, then get them to talk to each other because they can teach each other things. And if you want to achieve the best outcomes, then for some families, they'll need some other support, whether it's social worker support or nutritional support or outreach nursing to their home. Not always, but many families will need that. I think there's some training needs we have for chronic diseases too. And certainly I think for paediatric nursing training, paediatric nurses can be very important for the management of chronic diseases, and they can be sometimes the coordinators of care, the care coordinators for these patients. And if a written management plan is in place, then often those paediatric nurses trained properly can be help manage those children in conjunction with a paediatrician. And I think we need more training for medical students and paediatricians during the Masters of Medicine training, chronic disease management, so that we can all be better at it. Okay. Right, well, look, that's all I wanted to say today about chronic diseases, but I think you can see that there are many conditions that rather similar, that have similar characteristics, and if we focus on chronic disease programs, then we can be better at looking after these children. So thanks for your time today. I'm just going to stop the recording, and then if you've got any questions, I'm happy to answer them. So thank you.